reckoning is finally here. No justice, no peace for too many years. We're marching for equality in every state.
Hello, everyone. My name is Ginger Graham. I am a member of the advisory board of the Tom Tom Foundation and community volunteer here in Charlottesville, Virginia. On behalf of our team, I want to thank each of you for being here. Today's event is part of a 7-week virtual series called the Cities Rising Summit. Cities Rising will explore critical issues surfaced by the COVID-19 pandemic and movement for racial justice, especially as they relate to small and mid-sized cities in America. All Cities Rising events will be available on a pay-what-you-can scale, thanks to the support of our sponsors and community members like you. If today's program resonates with you, please consider becoming a contributing member to the Foundation. You can do so on our website, tomtomfoundation.org. Any donation you make is tax deductible and helps ensure that we can continue to do this work in the months and years to come. The Cities Rising Summit will run until October 30th, and we encourage you to get as involved as possible over the course of the coming weeks. Join us at weekly meet and greets and interactive change maker sessions. Connect with our Slack workplace, and please email our team at any time with your questions and feedback. All talks throughout Cities Rising will be recorded. So if you enjoy today's session, please subscribe to our YouTube channel and share these speakers and ideas with your colleagues and friends. Please note the chat function in the bottom right corner of your screen. You can use that to ask questions of our speakers, share your lived experience around these issues, and connect with participants on the call here today. Also, please note the Q&A function. Our moderator will have their eyes on that channel and will include your questions and insights into how they steer today's conversation. The title of today's talk is Black Table Talk, the Black Maternity Crisis, and features 4 luminary Black female doctors leading advocacy and day-to-day practice in the space. This event is part of a week of thematic programs around health equity and is brought to you by the Hartfield Foundation and Goodstock Consulting, who we thank for their incredible support and collaboration in building this program. With that, I am pleased to introduce you to our moderator for today, Ebony Hilton, an anesthesiologist at the University of Virginia Health System, who in 2013 became the first Black female anesthesiologist to be hired at the Medical University of South Carolina since its opening in 1824. In addition to being a medical pioneer and expert in health disparities, she is also an accomplished children's book author and community activist based right here in Charlottesville. Ebony, I'll turn it over to you.
Well, I thank you for that, Ginger. And, I want to thank everyone for actually joining us. This talk, I hope, leaves people motivated to not just listen, but to act. And we have some amazing panelists to drive home this idea of how to put legs to this talk. Now, because this is a heavy topic, I'm hoping that we actually fix some things, that we prove this topic to be irrelevant within the next 2 generations. And what is this topic? Well, it's maternal mortality, particularly as it pertains to Black women. Now, it's said that you can actually tell the overall health and social condition of a nation by reviewing the outcomes along the lines of maternal and infant mortality. Reason being is that these 2 demographic groups, infants and women, they tend to be overall really healthy, right? These young women, they shouldn't just necessarily die. But if it is an indicator of health, then America is in serious trouble. You see, we rank 55th in the world in terms of maternal mortality. And in fact, if you take the top 10 wealthy countries, we would be at the bottom of those 10. We are the only developed country that has seen a rise in our rate of women dying in the recent decades, with our rate of death being about 17.4 per 100,000 live births, and the next country of the UK, finding theirs at 9.2. So we're nearly double them. And the only thing worse than hearing that is if you're an African American, because see, African American women, we're found is that our race is an independent risk factor of whether or not we live or die. Black women die at 3 times higher rates than white women nationally. And in some cities like New York City, that rate jumps as high as 12 times. And my question is, why is that? And so I'm so glad I do not have to answer that question for myself, that we have these amazing panelists that can answer that for us. So without further ado, I would like to introduce each of our panelists so they can introduce themselves and tell us exactly who are you and what are you doing, your individual hats of uprooting this disparity. So we can start first with Dr. Kanasha Gleaton. Dr. Gleaton?
Hello.
Yes. So can you introduce yourself?
Yes, so I am Dr. Kanasha Gleaton. I'm a practicing OBGYN in Charleston, South Carolina. I work for Roper St. Francis Healthcare as a generalist within that practice. And most recently, I became the medical director of Natalist, and we are a company that is aimed at improving outcomes in pregnancy, but also in terms of infertility. And so we love all things pregnancy, and I'm really excited to be representing them today in this panel.
Well, thank you very much. And Dr. Joya Perry.
Hey y'all, thank you so much, Ebony, for inviting me. So hi, I'm Joya Perry. I'm an OBGYN by training and the founder and president of the National Birth Equity Collaborative. And we're about 5.5, almost 6 years old, and we work to improve birth outcomes for Black birthing individuals, both in the US and internationally. And we do that through research, advocacy, and policy shift, and it's also culture shift. So excited to be here with you.
Thank you for being here. And how about Dr. Rashonda Mitchell?
Hi, everyone. Hi, Ebony. My name is Dr. Rashonda Mitchell, and I'm currently a third-year maternal fetal medicine fellow at the University of Virginia. So for maternal fetal medicine, basically, I specialize in high-risk pregnancy. So, you know, I have a special interest in high-risk pregnancies and specifically women of color.
Very nice. So as you guys can see, we're going to have a well-rounded conversation. And just to bring our audience up to speed, Dr. Gleaton, what exactly is maternal mortality? When does this happen? What does it encompass? And is it only difficulty labor? Like, what are some of the causes of us dying?
Yes, Ebony. So, you know, I wish it were as simple as just labor, right? So we are all very well versed and trained in handling difficulties within labor and labor, determinants that would necessarily affect one's overall well-being. However, it's not about labor at all. Typically, these things happen early during pregnancy and in the 3rd trimester, as well as up to a year postpartum. And so these conditions, many of these women come into pregnancy in a more unhealthy state, and it definitely affects their pregnancy, but overall their outcome really, and it's definitely a big deal.
And I know
one more thing I wanted to say, Ebony, is that it's defined as any maternal death during pregnancy, as well as up to 1 year postpartum. So it's a very long time frame that's considered.
Right. And how many of those births are all of these women dying? Is there anything that could potentially keep them from dying? How many of those are considered preventable?
So yeah, unfortunately, 60% of those deaths are considered preventable. And when I say preventable, I feel like often people say, well, you know, I knew it was the hospital or I knew it was the doctor. And that's not necessarily the case. When you say preventable, it means preventable on multiple fronts. So it's not always the doctor. There are certain things that the doctor can do, but certainly there are things and protocols that the hospital systems can initiate, as well as certain things that a patient must know that affects their overall health outcome and pregnancy outcome. So I think it's definitely multifactorial, and it's going to take a systems comprehensive approach to be able to affect the efforts and the outcomes and change this startling statistic.
Gotcha. So 60%. Now, when I hear 60, regardless of where the blame falls, my question is, that's 60%. That's over half of these women could still be alive today. So I guess my question, Dr. Perry, is, well, then who are these women? Are there certain types of women, certain demographics that fall prey to dying in this peripartum period?
And I love Dr. Gleaton explaining to us the up to 1 year, because there is kind of this controversy that we currently worldwide only count up to 42 days. And that definition was really created without any science. We do a lot of things that we historically have done. Nothing magical happens in 42 days. People are dying from cardiomyopathy, as we know. That Erica Garner, who was the daughter of Eric Garner in New York City, who spent months reenacting her father's murder, died of cardiomyopathy 6 months after having a baby at 28 years old. And so it's important for us to really expand how we count and expand our definitions. And really, the C.D.C. in the United States has up to 1 year, and we would need to push the international community to do the same. It tends to be, people want it to be the high-risk people. I love that Dr. Mitchell's on as the MFM, because who has been really in the United States leading the charge around figuring out maternal mortality has been high-risk OBGYNs. And the problem is that's not going to help us to get to the solution, because so many people that are dying are healthy individuals. We've seen people who have no pre-existing illness, 19, 20, 25 years old, but they are Black women who are not listened to, who are not heard, who are not believed. And so unfortunately, that independent risk factor of not being able just to see somebody and pick the biases around obesity or poverty don't match who's actually dying in childbirth in the United States. So in places like New York, California, North Carolina, when they look at their data, they can't just look at someone's skin or their weight and say, you're the person that's gonna die. Because unfortunately, it happens really quickly, and we don't have to put the systems in place to really listen to people and evaluate them in a timely manner. So as was mentioned, that patients don't know what to look for, and we are not doing a good job of holding them in a space where they are listened to and heard.
And when you say they don't match, you said obesity doesn't match and income doesn't match. What do you mean by, for the layperson that's just hearing statistics?
For sure. Well, I love even talking to them, like these beautiful Black women on this phone, when I explain to them that despite income or education, we are still more likely to die. The C.D.C. released a report that a Black woman who has a PhD or an MD is still 5 times more likely to die in childbirth than a white woman who has the same education. So when we have made these assumptions that, there's only people who are poor, or only people who are obese, or only people who have pre-existing illnesses, the data does not bear that to be true. And the truth is, many people who have none of those things are actually dying within a year of childbirth in the United States.
It's troubling, because there's also studies looking the same at infant mortality, where even with higher attainment of education, like all the women, we are all physicians, and yet our children are 2.5 times more likely to die than a white woman with a 4th grade education. And so, that brings me to my point, Dr. Mitchell, we are all physicians, but before that, we're all 3, 4 Black women, and you 3 are actually mothers. So as you were approaching this idea of going into motherhood, what were the questions that you had for yourself? Because oftentimes we think of these numbers and we're like, that's someone else. But how did it shape your entry into this prenatal phase and into pregnancy? And what has it been like post?
I will say, with the, recent public awareness of Black maternal health and the disparities within it, I think going into pregnancy as a well-informed, educated woman, I had to consider a lot of things. And some of the things I had control over, and I want to speak to what Dr. Gleaton said, and as well as Dr. Perry, is that there were some things I had control over. So I wanted to I'm considered, I guess, advanced maternal age, as we would call it. And so
what age is that?
Age 35, you have to be at age 35 or above. So going into this, there were things that I had to consider, that I was already at risk. As she said before, your career and things like that already put you at a greater risk. So I will say I approached it with fear, which is what I am seeing amongst a lot of colleagues. They are scared. They've worked hard to get where they are in life. And then to consider having a child and knowing that you could be a statistic and die just from obtaining that one goal or desire in your life, it's a little bit troubling. And when I say things that I had control over, so the one thing a couple of things I had control over was my total health. So I was a runner before. I said, I want to be in the best shape I could be, because I know there are some things that are working against me. I wanted to be at an ideal body weight. I wanted to make sure I didn't have any chronic or manage any chronic diseases that I had prior to. So these are all things that I had control over, but there were things that I don't have control over. And one of those is being Black. And then the other one, I have to honestly say, is my age. So those were things that I had to take into consideration when considering having a child. And, you know, I'm now currently 9 months out, but I will tell you, even though I attempted to do everything right, I still had a complication of pregnancy. And we can go into more detail about that, but definitely those were things that I had to consider. And I think a lot of women who are considering pregnancy should take into consideration when you want to optimize your outcomes. And there are things that we can change and there are things that we can't change. And we can go a little bit more into detail as we go along in this talk.
And you know, and I think there's no greater time than this, you know, because as Dr. Perry stated, we can have higher levels of education, more resources. I mean, we're all friends. We have our friends that are cardiologists and you know, neurosurgeons. We have literally people in our phone book that if anything happens anytime throughout the day, we can immediately get an answer to, right? So I think it'll help our audience to understand, because I think we get a picture of what we feel like Black maternity looks like, and to bring that home to say, no, it looks like us. You know, it looks like every one of us. So if you would share what your experience was, I think that might help to drive home this idea and this notion that we have a big problem in America that we have to address.
Yeah, so for me, my pregnancy was pretty much uncomplicated until the very end. My water broke. I was at work. I'm an OBGYN, so I just went to labor and delivery. And however, during that time, you know, I will say that probably more than anything, biases began to sneak into my care. And that's being a well-informed person who was attempting to advocate for myself during that time while you're in labor. And of course, there were a couple of dynamics that played a role into probably my care. I also had a complication where I almost ended up on dialysis. Like, I was in hospital for 7 days. I needed what they call blood exchange, a blood exchange for my platelets. My platelets were severely low. There were a number of things that happened medically that could not be described. But when I tried to express those concerns, it was looked upon as though you need to just be the patient instead of being a doctor. And I can't separate those two things because I'm both. So because I had questions, and I actually ordered a couple of tests for myself because that's what I needed to do, because I felt like they were not happening. And I had to become an advocate for myself. And I say all that to bring in other things and dynamics. My husband was there with me and he was scared as well. And I had to prepare him going into this. Our partners have to be prepared to advocate, you know, and it's a sad, sad conversation that you have to have with your husband, that if I'm ever incapacitated and unable to advocate for myself, you need to tell them to fight for my life. And to think that at such a joyous time in your life where you are planning to have a baby, that you have to have that discussion is disparaging, to say the least. So it was a very difficult time for us, but we made it through. We're grateful. We have a wonderful, healthy baby boy, but it was a challenge, and I will have to say that probably biases, and I am well informed of what care I can I can receive. I know the guidelines and the things I wanted to advocate for myself. I wasn't listened to, almost to the point where it was, well, if you don't like what I have to say, you can consider another physician. That it was everything was out of the field once I became a patient. And I think I know I would like to advocate for physicians to listen to their patients a little bit more when they are telling you something is wrong, or you know, I think they should allow patients to take a more active role in their own care. Really.
And go ahead, Dr. Perry. Sorry.
No, but I thank you so much, honestly, for sharing that. I know it's, we work with a lot of you're a near miss. That's what you really are. And the stories, the difference between a lot of times a near miss and someone who dies is they had to fight for themselves. Almost always, every story is, I ordered my own blood test, or I took a picture of my own necrotizing fasciitis and was like, this is what this is, right? And so the truth is, as long as we don't listen to patients, as long as we believe we know best and you know nothing, that's how we get here, right? Like that is truly that dynamic of hierarchy of us not listening and thinking that patients have no personal bodily autonomy. They don't know anything about them. They thought that about you, and you have as much education as they do, right? Or more. So imagine when a patient who comes in who is not you, and then they start feeling threatened, and I say they, but it's really we, because we're also OBGYNs, right? And so I feel like my colleagues sometimes, who are fellow OBGYNs, get very frustrated with me when I make these statements. But when you're the patient, you know it's true. We were trained to just say, you must do. And that doesn't work, right? Like when you're laying there saying, I know something is wrong, to have someone just say, you're wrong, makes no sense. It's my body. I know something is wrong. You should validate my experience, you know?
And the question is, you know, like I said, you know, Dr. Mitchell said she almost needed dialysis, which means that her kidneys had stopped working. She was not making urine. She noticed in her Foley that it was the Foley bag was completely
It was nothing.
There was nothing there. And we hear stories of Serena Williams, who says that I have had this pain before. I know I have a blood clot. You need to check me, right? We've heard of even Judge Hatchett's daughter-in-law, whose husband was advocating and pleading and saying something is not right. Someone needs to check her. And hour after hour after hour, he pleaded with people to help. And unfortunately, hers is a case of where, even when pleading and advocating, his wife, a mother of two now, spoke 5 languages, really fluent, resources at fingertips, and she is now dead at a preventable cause. And so we had a question that came up in our Q&A that I thank the anonymous attendee who posted it. It says, I almost died during childbirth from preeclampsia. My life was saved by the bold decision of a Black perinatologist who trumped my OBGYN's recommendation to send me home on magnesium sulfate to stop my premature labor. I was already entering into DIC, and it was ignored. And for DIC, for everyone else, that's basically a blood disorder where you're consuming all of your blood clotting agents because your body is in this inflamed state, and so you can have the potential to literally bleed out. But it's a pro-clotting and then pro-bleeding kind of phenomenon that happens. She says, how can Black women advocate for women who don't have others to advocate on their behalf? I'm a pathologist by training and was healthy before my pregnancy. Dr. Gleaton, would you like to weigh in on that? So
Absolutely.
what if you don't have these letters behind your name and you don't have? Yeah.
Right, absolutely. And it's pretty discouraging and alarming at the same time, because we do know that so many women don't have like MD behind their name. We're the minority, right? So we do not represent most African American or Blacks in the United States. So it's important that we have forums like this. It's important that we bring awareness to this situation, because before a couple of years ago, I feel like this was like not spoken of. Like these statistics are not new. It's just now that we have a national spotlight on these statistics and people just don't know about it. I've had lots of patients who knew something was wrong. However, they were talked out of something being wrong by the doctor, who obviously went to medical school. So of course the doctor knows more than them in their mind. but the doctor is not inside their bodies, and patients know their bodies best. So I think we have to educate our family members, our neighbors, everyone that we come in contact with, to make sure that you fight and empower yourself, because you know your body best, and know that you can ask for a different provider. Like, you can fire your provider. A lot of people don't know that. Like, nurses and doctors are fired all the time. And if there's ever a reason to fire somebody, it's because you feel like your life is being threatened. I mean, you only have one life. God gave us one. You got to protect it.
Now here's the thing. What's the cost of that? So if Dr. Mitchell, you said, you know, your pregnancy was uneventful. You're going in, now your water has broken. If I'm telling you, you can find another physician, your water has broke, you're at 10 centimeters dilated, your baby is coming out regardless if you want it to or not, and there is no other physician in this hospital. What do we do? And what is that emotional, I guess my question is, what does that emotional stress do to the pregnancy, for one, your delivery experience, for two, the influence, and this is gonna be a lot of questions, so I hope all y'all listen, the influence and the impact that has on postpartum depression, that we know is a real condition for our mothers to have to deal with. And in particular in the Black community, where we know stress and anxiety is already undertreated, right? How does that all feed into the development of us having even chronic illnesses associated with pregnancy, including gestational diabetes and heart failure and so on?
Well, I mean, that's a large question to bite off of. But first, let's start at a small level. I think the first thing we can do is, one, I think as a community, is educate our women. I think sometimes we have left that part of pregnancy out. Nobody wants to talk about sex and pregnancy and everything else. And I think it's an important part of just culture for us to address some of the things that are associated with pregnancy. And that's the good and the bad. There are great things associated with pregnancy. And there are things that you need to prepare for mentally, physically. And we don't talk about those things, because if someone would have warned me about breastfeeding, I think I would have been more well informed. Not that I didn't want to do it, but it is a challenge. However, those are things that I think we miss. So one is we can educate ourselves and our community a little bit better. And one of the things I would push for is better health literacy and educators in our community. And if we don't have those, we need to begin to develop those. And I do think we have an infrastructure, although we haven't put it in place. And we've heard, and we'll talk more about it, like doulas can be used in that place to help assist the care of the pregnant woman, to help provide them with information, accurate information, to help them prepare for pregnancy, labor. Because some people.
Can you explain what a doula is?
A doula is someone who assists like in the emotional and physical portions of prenatal care, pregnancy, and postnatal care or postpartum care. And basically they're there to help guide the woman through that process and have a support system. And in some areas, they also assist with women who are actually having abortions, somebody that they're there to support the woman through whatever choice that they are making. And I think we have an infrastructure that we need to kind of put in place. It's not well developed yet, that I think we could have a better outcomes, because I mean, there has already been research shown, there was a Cochrane review, that doulas do help in the total outcome, better outcomes. You have more vaginal deliveries, less use of pain medication, less operative deliveries. But I do think there's a place, but we need to put them in place. The first thing we can do is educate ourselves. The second thing is educate our family, make sure we have those advocates such as doulas and everyone else. And then we could go down the structure. When you say stress, of course, the stress of immediate labor may not have a direct effect on the overall later development of your child. But I will tell you, there is something called like post-traumatic stress of pregnancy. And I will tell you, from everything that happened with me, I'm not sure that I want to do it again.
Right.
And that affects my family planning. And so that is something that people have to understand. It does affect a woman's desires you know, to extend her family. And I think that's something that we need to address, is also the mental health component of pregnancy in and of itself. So I think what you're aiming at is that there are institutional things or structures in place in our society that contribute to some of the morbidity associated with some of the women who are associated, that come in and are pregnant. And when I say that, I'm saying like food deserts in places where you have high rates of diabetes and obesity. So these women are already coming in with certain specific diseases that put them at risk for certain things when it comes to labor and the postpartum period. And we can go into much more detail about that. So I think the first thing is education. The second thing is that we need to really consider the social determinants of health, basically. And I'm sure Dr. Perry can go into more.
Right, because that's exactly what I was going to ask. Dr. Perry is key.
Yeah, right.
And what is that? So for our listeners, what are the social determinants of health? Yeah. And how does that play into Black women not only bearing ourselves at higher rates, but our children at higher rates, and our husbands and our sons at higher rates?
Yeah. So first thing I want to just unpack, just for all of us, just for as men, is that so Blackness is not genetic. There's no Black gene. There is no Black gene. And also the Bible, God, Jesus didn't put us on different continents so we wouldn't mix, right? So all this idea is that the reason that Black women are dying in childbirth is because we have different kidneys or different lungs, or that our vaginas have more bacteria in them. All of those are coming from a racist framework, a belief in a hierarchy of human value based upon skin color that's existed for about 500 years. And that belief is embedded in our policies and our laws. I can tell you that I was in medical school in the late 1990s, and I was taught in embryology class that there were 3 biological races: Mongoloid, Caucasoid, and Negroid. So many of our colleagues that you're working with, that are teaching at your institutions, even though if they stopped believing that, even if they finally, the Human Genome Project completed in 2003, so we have finally had the president come out and say that there's no biological basis in race, they still have it in their heads. They cannot let it go. Every time I do a training, every time we do a talk, they still say, but it's just something different about y'all, right? You look different. Why can't you be different? And I can say I have about 45% white genes from Europe. My daughter did the 23andMe, so I don't know why my white genes don't cause problems. And magically, the ones that come from the continent of Africa cause diabetes, hypertension, everything. Schizophrenia, mine. Those genes are amazing how that happens. Anyway, so the point is, social determinants of health really are created. There are different outcomes that are created when you don't have access to food deserts, as Dr. Mitchell mentioned, or you have lack of pollution. Like some of the places have high rates of pollution, and you have lack of quality education, but that comes from the root causes of racism, classism, and gender oppression. So I don't want people to think we just have social determinants and we can social work our way out of it by doing a consult to get somebody access to some food at the food bank. What we have to do is invest in undoing racism, classism, and gender oppression.
And that's why we have you on this panel. So for listeners, there's literally a phrase called necropolitics. And these are policies that we know are in place that directly have a negative impact on whether or not you live a healthy life or a life that's more prone for you dying. And it was actually coined by a philosopher, I'm going to mispronounce his name, is Achille Mbembe from Cameroon, but it literally is called necropolitics. So look into it. But there are works, I do want people to come away from this being hopeful too, because there are good outcomes. And so Dr. Gleaton, I know you with your works with Natalists, you all are very heavily invested in keeping not only mothers alive, but have healthy babies at the end of this through all works. So can you tell us about some of the initiatives that are in place that you know of that does work? What are some things that can be done to uproot and kind of overcome these social determinants of health and factors that stacked against us?
Yeah, absolutely. Just in general, I think that, again, it's such a comprehensive model that needs to happen to impact change. It's so easy to focus on the patient and say these patient factors put us at risk, and so easy to focus on the provider. But I think until we come together comprehensively, and I'm really blessed and graced to be a part of natalists, because they really understand that there's so many factors that affect pregnancy as well as infertility, but there's so much misinformation. Like Dr. Joya was saying, like there's a lot of misinformation. People think that Blacks are inherently different, and so we inherently have all these risk factors, and that's why we have bad outcomes. And for us, or it's because we eat sausage dogs and we eat so poorly all the time, and that's why we have like kidneys that don't work. And so it's important that we kind of undo some of that, but a lot of it is just empowerment and basically bringing awareness. And so that's what we aim to do. We aim to not foster any junk science, but everything we put out there is actually educational in terms of it's being scientifically backed. We research our stuff before we can put it out. And so that is a huge time commitment, but it's important with our CEO, Hallie, that we do that. And so everything that's on there has some kind of study backing it. So, you know, when you go to the site, you have realistic information. But again, it's not just from our standpoint. Of course, you know, there's legislative change. I know Dr. Joya works a lot with that, but there's so many things that need to go into impacting change, and it has to be a systematic approach, or we're not going to get very far.
And speaking of systematic approach, there's been some fantastic questions that I want to get to in our Q&A panel. And so one is from Dr. Rick Foster, who's from, if you don't know him, he's in South Carolina.
Hey, Rick, tell him
I know. That's one of those where you see him, you're like, oh my God, this is like, all right. So he says, his question is, how do we best ensure that the non-clinical factors that most directly contribute to racial maternal outcome equity gaps are effectively addressed, including the lack of respect from the clinicians?
Yeah, so we've been working for about a year now on a framework for respectful maternity care. We have some funding through the from the Robert Wood Johnson Foundation, along with the American College of OBGYN, and we interviewed Black birthing people to see what does it look like to have respectful maternity care? What do they think that means? And so some of it is resonate that you'll sound familiar, right? Like, you know, people want to be listened to, you want to be heard, but we really learned something that's a really important thing. And I think my colleagues here, we've talked about it a little bit, is trust building. And it's not the way that we talk about it in healthcare right now. There's a lot of things, if you look on this website for like HCAPS and all these other things, they talk about trust, but it's always, how do patients trust us? We want to build trust. Patients want us to trust them. They want us to see them as valuable and as trying hard, and they're not non-compliant. They got 3 jobs and 5 kids, and they're trying to do the best that they can. I mean, we just did a telemedicine thing, and one of the doctors complained that they don't have their protected time through telemedicine with the patients. When is my time ever protected? All right, now I'm waiting for my 9-year-old to come do his little dance behind me, right? So I don't even know, like, protected time is such a concept that has nothing to do with the real lives that we've all ever lived. We all have always had multiple things going on at all times. And so until, Rick, we can really build in that trust where providers trust patients, where providers believe in patients, where we value patients' opinions, their ideas, they see this as, and we can let go of needing to control them, right? Like if I give you the information, if I say to you, ma'am, if you try to do this VBAC, might not be a good thing. And you say, I hear you, doc, I trust you, and I still want to try. That's not my job, is to call the lawyer of the hospital and make you lay down, like all of that need to control and that need to feel like we're the most powerful and we know better. That's where we're going to have to let that go and really start trusting patients in their bodies.
And that brings up a good question. You know, is there a criminalization with Black women having higher rates of disparities and dying at higher rates? Is there a criminalization of the Black body when she walks in the door? And someone made a great question in the chat, and I'm trying to find it one more time. Yes, the question was, what are your thoughts on the effectiveness of implicit bias training for providers and personnel to impact this alarming disparity? Because we know these disparities, just to give our listeners an idea, Black women have been dying at this rate since 15 years before the Civil War. This is not anything new. We have always died at higher rates. And so does implicit bias work and implicit bias training work? I see you smiling.
Well, I mean, I'm smiling because it's how I eat, right? So people pay our organization to do implicit bias training. We go in and talk about structural racism and gender oppression and white supremacy culture. So, you know, implicit bias is the entry point. It's the entry into a conversation. And until we can actually change our textbooks to undo like the things like saying mongoloid, caucasoid, negroid are biological, then we're going to have to do these trainings, these kind of webinars, having consultants to come in, because our actual textbooks are teaching, honestly, we have a calculator for VBAC that include, or for having a baby by C-section after, I mean, vaginal delivery after having a C-section, that includes race as one of the things that you would link to that without thinking about. So that means that a person can use that and tell a Black patient, well, you're gonna have to, this calculator says, because my other racist colleagues, I've been cutting all the Black patients, that I gotta cut you too, right? Like, makes no logical sense, the choices that we make in our current healthcare structure. So yes, I don't think implicit bias is the panacea, but I do know if we don't get new and the actual real truth to nurses, front desk staff, people who answer the phone, not just the MFMs and the OBGYNs, the entire spectrum, outpatient, inpatient. If we don't get the real truth about science and that race is not biological and that we have all these other risk factors and racism is real, we're gonna keep seeing Black women die in childbirth.
You know, and that's okay. So that's definitely the training. One of the questions that's in the chat that says, you know, Dr. Mitchell, you said that you can fire your provider, but what vocabulary should the patients use if they do want to fire? How do you walk that fine balance of being an advocate for yourself versus being thought of as being an aggressive patient and we're now annoyed by you rather than listening to you?
Right. I think this is something that I think women of color have to deal with in a professional setting, whether they're giving birth or anything else. If anytime we assert ourselves, we are often thought of as the aggressor. And for me, I will be honest with patients. And I think you should have a provider that you can have a relationship with, because I want you to have the best outcomes. If you don't work well with me, maybe you like a male provider, that's fine. I'm okay with that, because I want good outcomes for me as well as you. So first of all, I think as a patient, you can say, well, I don't think that we have a beneficial relationships where I can have the best outcomes. Can you refer me to another provider and work with them that way? And I think it's appreciable from every perspective, even if I think that I may not be the right provider for someone else. Sometimes it may be better for my colleague to take care of that patient. And if I can do that and offer that to them, I am okay with that, because I want my patients to feel comfortable. At the end of the day, I want my patients to have good outcomes. So I think we can have that discussion in a meaningful way to say, well, I don't think this, you know, patient-doctor relationship is beneficial, and maybe we should consider, you know, finding another provider for you.
And this, sorry, go ahead.
I was going to say the data shows that people don't switch doctors. And so we really want people to feel comfortable that you can, and that if your doctor is fighting you about switching, they're not a good doctor. You should definitely switch. I want people to feel comfortable, so please switch.
Right. And I go ahead,
Dr. Clayton.
I'm sorry.
Dr. Clayton.
Oh, no, I was just saying that because I was just going to say as well, I think it's important because many of these things happen, like the life or death things and mortality happens in the inpatient setting. And I think, Ebony, you brought up a good point. It's difficult when someone has been, you know, caring for you in terms of your labor process, and you've been there for 36 hours and then all of a sudden just try to bring on a quarterback. However, I think it's important that we all recognize, and a lot of people don't know this, I didn't know this until I started working on the unit, that there are teams in most hospitals that are available to be called if you feel like your life is in danger, or if something is going on that does not suit you best. And in our hospital, it's called the Rapid Response Team, but these teams, they're called acute care teams, but these teams bring in other individuals, not just other doctors, but other individuals, including an ICU nurse, and a respiratory therapist, sometimes an ICU attending, various people who have expertise and can quickly give you a second opinion without saying, hey, will you call in another OBGYN from home out of their bed, because that's probably going to be pretty difficult. But these teams are already in place, on call in the hospital, can be there within 5 minutes. You can get a quick additional assessment on your care just to give you a second opinion in terms of making sure that you're on the right track and not in danger.
And this might be a great time to, again, advocate for the use of doulas, for the use of midwives, of people that have been with you throughout your pre-pregnancy, your prepartum, you know, before your birth. And they're now in the room with you, and they can be advocates or at least a sounding board for you. They can't direct your care necessarily, but do you guys know of any even hotline? And maybe this is something that needs to be developed when we're talking about action points of coming out of this, of where a woman can call a number. Right. Because again, it is one of these things of, do we have access to doulas and midwives as we should? Is that also a disparity in the two groups, right? And maybe you guys can talk to that. But two, if I don't know medicine and someone, and whether it's a doctor or a nurse, is telling me, no, this is what it is, I may be afraid to push against that when I'm trying to push out a person, right? So is there a hotline where you can call and get a second opinion, or have someone advocate on your behalf? Because if I'm from Little Africa, South Carolina, we don't have multiple doctors in our hospital. At night, we may have that one. So
yeah, I mean, I think it's part of the problem we have right now, because we've now spent the last kind of 4 years really building up the information around the Black maternal health crisis. And so people want accountability, and we have no structure for accountability, not even inside of hospitals, even to the point of what happens if you're sitting in what happened to Dr. Mitchell, right? Who was she supposed to be able to call to make sure that she was okay? So right now we're still kind of counting on poor doulas to like fight for us. And then what happens to them when they start kicking the doulas out of the hospital? Like, we've created no real structure in the system. There's an Earth app, which my colleague Kimberly Seals Alice put together, where people can, it's kind of like Yelp for birthing, this birth without the B.
Okay.
But we don't have really, so we're trying to embed, working with Joint Commission, working with HCAPS, putting it into the structures of quality improvement, and then also requiring people to have posting, like, where would you call if something happens? Because you don't want to just tell, if the nurse who's laboring with you is the person that's problematic, how are you supposed to be in labor and work with her?
Right, right.
Yeah.
Did you have something?
One of the things I was going to say now, we understand that labor is just one of those things where if it's happening, it's happening. And you may not have a day or 2 hours to make a decision, unfortunately, because it may, reflect in your total outcome of your health and the health of your baby. And I think that's where, as Dr. Perry was saying, we don't have a structure in place where women in that moment can have someone who that they can contact if they have like a second opinion. And these are women that don't have a medical background, and I think would be advantageous for women to have access to that. And as we were discussing implicit bias, I think, yes, implicit bias training is essential and important. As we were discussing, I think there have been structures put in place for so long. The Constitution was not built with us in mind. Okay, let's just start from way back then. Okay, it was never built to be advantageous for us.
Right.
Now, if we go along in society in this great America that we have helped build, everything that we have as people of color, we have had to fight for every civil right, to vote, to exist, to do everything. So there are structures starting back from the Constitution that have never benefited people of color. Now, because this is so insidious, some people don't even realize that these structures are put in place because it's normal. It's everyday life to them. So I think the training is essential because the history books do not reflect the history of people of color and the things that have been put in place and that we've had to endure. You hear about the same things if you go through our education system, everything when it comes to Black History Month and all of those things, but you don't hear about the other things that were put in place. And they always say the history is written by the heroes. So the people who suffered, people don't know their story. And so I think we have to undo that. And I think implicit bias training is essential, but there also needs to be a measure. If you've had this training 5 times and your outcomes are still poor, then we need to address
accountability. Accountability. So I mean, we're seeing that with the police movement right now, right? Like, so a lot of policemen have been trained, but they never put any accountability structures. And so that's the moment, and that's where we're coming. So people need to get ready so you can go home and complain about Black folks all day, but you can't show up at work and behave in a way that is racist and harms us. So that's really, so people ask me all the time, you think you're going to end racism? No, but I do think I'm going to hold you accountable if you behave in a way that harms my people.
Right. We need some report cards.
Yeah.
And, you know, and I say all the time, you know, women birth nations, of course we can run one. So when we're talking about, you know, policies, as you bring up the Constitution, literally, I say all the time, don't talk to me about the Constitution. I'm an amendment. I'm an amendment to the Constitution. My every existence is an amendment. And so, but that being stated, I do feel like, you know, like I said, women, we birth nations, of course we can run one. So what policies, we know with the influence of the ACA, we had some major shifts as far as pre-existing conditions now being covered, right? What policies do you all think need to be addressed as it pertains to maternal health or women's health just in general? What is left out? What do we not include right now in forms of insurance or programs, you name it?
I feel like I talk too much, so I'm gonna wait for y'all to go first.
Y'all like to help people.
Exactly.
Right.
Well, I think one of the things, as I said before, one of my biggest things is health literacy. I am a person, I don't want to give you a fish. I want to teach you to fish. Mm-hmm. So if I can provide you with the information to fend for yourself, that is what I think is so essential. And there are different levels that you can teach people to advocate for themselves. And I think that is a portion that we're missing in the community on the onset. And if I had to look at the end of pregnancy, where we see a lot of our maternal morbidity and mortality, I think Medicaid should be expanded for a minimum of 1 year for women. If we're going to count births or the maternal mortality ratio is up to 1 year, then we need to cover our women with insurance and allow them to be able to access health care for at least 1 year and provide them.
Right. And what is the coverage in South Carolina, Dr. Glean? I know here in Virginia, when I first moved here, there was an announcement that they can have paternal leave for 8 weeks for men. I thought that was incredible that we're actually allowing women to have the support of their husbands and their significant others at the house so they can heal from the fact that you just pushed out a whole person. Don't even get me started on that. But how is the medical coverage? I'm from South Carolina. What is it like in the deep South?
Mm-hmm.
Yeah, so we have about 8 weeks, 6 to 8 weeks typically, and then your coverage is over. So if you, for some reason, your appointment is rescheduled because your OBGYN is delivering a baby or doing something else, or you don't have transportation for that visit, or you have an emergency, whatever comes up, like you kind of missed that window. And so we know that a lot of these things that contribute to disparities occur after that 6 weeks. So that's a really narrow, or 8 weeks. That's a narrow window, you know, and so we don't have opportunities to address these things. And if you don't have access to healthcare and you got to pay $150 to go see your doctor, you're probably going to spend that on something more meaningful for your family, as opposed to dishing that out if you think all things are going well. But as we know, things can go awry pretty quickly. So yeah, we definitely need to expand coverage, not just for postpartum though. I think preconception visits, we know that only 1 in 10 people go for a preconception visit. And this is where we have the grace to be able to control some of these factors like hyperlipidemia or high cholesterol and high blood pressure and all these things that could really impact the outcome of a pregnancy. And so it's unheard of for many of our folks to go for a preconception visit, which is super important.
And when you're talking about preconceptions, you know, Ben is writing us that we're at 8 minutes, which means sadly enough, we have to start wrapping up. But I do want to get this point through, especially with natalists. You all do a huge works too with women and infertility. And there was this statistic that I never considered, in that Black women have infertility rates of twice that of white women, and yet we seek help for that less often. Why is that? If we're talking about planning of families and having this, if we are waiting later in life and infertility may be an issue, what can we do to right that?
Yeah, Ebony, sadly, it's the same structural things that affect preterm labor and preterm birth and outcomes in pregnancy that affect infertility. So often we know that African American or Black women are not offered the same services as Caucasians or other races. So it's not even brought up in many annual exams. And I'll see a patient that's 40 years old and she's been seeing a different provider and no one ever asks her about her family planning. Do you desire to bear a child? And so it's really unfortunate because they come and they ask me about it and often it's too late. So I think definitely there's some work to be done in terms of educating providers and offering the same treatments and not just presuming that women cannot afford treatments or are not interested in treatments or might not have a partner. Like you have to delve into that and ask women about it. So it's important.
Oh, we saw a kitty.
Yeah, I told you, there's no protected time.
Well,
So we're the only industrial nation that does not have health as a right. So I love that my colleagues who are in Deep South states, I'm from Deep South, we're asking for minimum. We're asking for like, can you please just expand it for birthing people? But everywhere else that has as much wealth and money that we have, every person is guaranteed the right to health. That doesn't mean single payer. That doesn't mean how. We can't even agree that people deserve health. So that is what we could leave this conversation with, that we can all agree, especially during this pandemic, that everyone should have health. There should be no uninsured, there should be no preconception versus postpartum, that we should all have access to health.
Right. And I can't agree more. Like I said, you know, with COVID-19, it's uncovered a lot of things. But what I hope it has shown us and highlights is the fact that racial health disparities did not start with COVID-19. It won't end with COVID-19. And we really have to address all the factors that feed into why we're dying at higher rates. I say this phrase all the time: when a Black mother dies, does the world make a sound? We're dying and we're young and we have families and we have kids that are depending on us to live. And we're asking for everyone to get involved. We listed many different action steps that that people can do within their systems and their institutions, and that's implicit bias training, having some accountability and some metrics in place. But even in your communities, advocating for healthy eateries and advocating for these necropolitics and these policies that we know influence whether or not someone is healthy or not. We don't allow that to be shuttled over to the other zip code since it doesn't affect us, right? And then advocating for doulas and midwives and putting these in the community of those people who are high risk. We have to make up for this. We have to right this wrong so we can all live happy and healthy together. So we thank y'all for joining us. And please visit Dr. Gleeden with the natal list. Please, and everyone, state your websites and so people can visit where you are.
Hi, everyone.
Oh, sorry.
Go ahead. No, go ahead. Sorry.
Go ahead, Dr. Gleeden.
Yeah, we're at natalist.com. Definitely check us out, please.
Natalist.com.
Nationalbirthequitycollaborative.org, or birthequity.org actually is what the title is.
Birthequity.org, goodstockconsulting.com, and Dr. Mitchell.
Dr. Mitchell, you can come see me at the University of Virginia.
Thank you.
Thank you.
Thank you,
Thank you, doctors, so much for sharing your insights and experiences with us. And thank you, Dr. Mitchell, so much for sharing your story. This was a truly incredible conversation. And again, I cannot thank you all enough. Also, thank you to everyone in attendance today for being a part of this moment. If you enjoyed today's session, please consider becoming a contributing member to the foundation. You can do so on our website, tomtomfoundation.org/give. Your donation helps to ensure that we can continue to do this work year-round. We hope that you will join us for other programs throughout the Cities Rising Summit. This week, we are focusing on equity and community health. Right now, we're about to kick off a meet and greet with Kimberly Wills of Goodstock Consulting, where we'll be learning some facts that might surprise you about social determinants of health and further discussing these issues. We're dropping that link to the chat in the chat session now. And finally, we would like to thank our sponsors. Without their support, none of this would be possible. Today's session was brought to you by Hartfield Foundation and the wonderful woman of Goodstock Consulting. Again, thank you all so much. This was incredible and it was great to be a part of it. Thank you.
Thank you. Thank you for having us.
Y'all take care.
Thank y'all.
Bye.
The day of reckoning is finally here. No justice, no peace for too many years. We're marching for equality in every state, choosing love over violence, brutality, and hate. We're gonna stand.